to talk to you today is, I think, both a very personal and very hope to be professional story, both for myself and I hope for our department and I hope for our specialty. And I think that includes those of us that are anesthesiologists, but also those of us who are critical care physicians, perhaps those listening on Zoom. And so I think we have the opportunity to change the outcomes of our ICU and surgery patients in a very meaningful and unique way and prevent some of the long-term challenges they face, really what has become an epidemic of post-ICU and post-surgery disability, and really change that in the future. And then I'm also going to talk, as we move along, about things we can do for ourselves and things I think all of us can do to improve our own health and well-being. I think in medicine, that's always a challenge. And a lot of this information is fundamental things I actually didn't know till very recently, but I am compelled, I think, to share this with others because I think it will just affect all of your life and health spans as we move along. So if I can get my slides to advance, let's see. Hold on. Just maybe that'll get started. So this is the CME credit. Give you a second to look at this, and this can be texted in the next hour to receive CME for this lecture. And I'd like to, of course, present what I'd like to say not are my conflicts of interest, but are my alignments of interest. I'd like to believe I'm in alignment with the NIH and the DoD and the industry sponsors I work with, not in conflict. And I hope we're in alignment in trying to improve patient care and improve patient outcomes for everybody. And I think the key message I always start all my lectures with, no matter really what I'm talking about, and that is to say we must not only take responsibility on rounds every day as we talk about our patients and what we're going to do for them, with the things that are going to get them to the next minutes, hours, days, but what are we going to do every day for our patients that are going to get them back to the life they came to us to restore? Whether someone's having surgery or is staying with us in the ICU, these patients came to us not just to survive their illness or to get out of the hospital, but to become survivors. Survivors that go back to a quality of life that's worth living, go back to their families, and not turn out as victims. Victims that perhaps never go home, which is way too common, as I will show you, and perhaps never walk again or live in the house they lived in or go back to the jobs they held before. Because ultimately what our patients want from us is to be able to walk down the street with the people they love again, hold their grandchildren again, and go back to the quality of life they started with. And so the good news, first of us in the critical care world, I think it's true in anesthesiology as well, is that overall ICU mortality is decreasing over the last 10 years. But I think the question we have to ask ourselves is, in winning the many battles that we win with our better in-hospital medicine, are we too often also losing the war, much as this is a Pyrrhic victory, perhaps? As anyone who knows the story of Pyrrhus knows that Pyrrhus was a Greek general who invaded Rome, won every battle he fought, but ultimately had to return to Greece defeated because he eradicated his whole army in the process. So he lost the war by winning all the battles. And I think we deplete our patients in ways we'll talk about and in key areas we can change such that they're never able to go back to the quality of life they wanted. Because the reality is, although sepsis deaths and critical care deaths have fallen dramatically, we have tripled the number of people not going home, but to rehabilitation, where we don't know if any of these patients ever went home. And although we've improved hospital survival, how many of these patients even lived a year? Well, the reality is about half the deaths that occur after an ICU admission happen after the patient leaves us. And so that ultimately, the patients that we feel or we believe have survived and gone on with their lives, many whom won't even live but a few months. And that's what's led to a big change in our research focus in critical care. And this is both at the NIH and at high level. This is an ANZIC's publication where we should stop studying mortality as our endpoint, but quality of life should be our endpoint. And this is the question I often ask on rounds is, are we creating survivors or are we creating victims in the care we're delivering? And what can we do about that? And I think it's critical to ask our patients what they're actually experiencing and how they feel about that. So what do our patients actually describe their quality of life and what's it like to be an ICU patient? I think a great illustration of this is actually a patient that I have met a few times. It's actually a patient of Wes Ely's at Vanderbilt. And she was seen by the SIB Center. Wes was a visitor here recently. And she was a 58-year-old young woman who in the past had gone through 20 years ago, 2 years of grueling chemotherapy for leukemia. And she'd been in remission now for about 20 years. And a few years ago, during one of the influenza epidemics, she developed a 3-day history of influenza, came into the hospital, ultimately developed ARDS, and ended up on the ventilator, was in the ICU for 3 weeks. And after 23 days, she was discharged, not to home, of course, but to a long-term care unit. And we as the physicians applaud ourselves because she must be better, right? She's out of the hospital, out of the ICU. But the question is, was she a success? And I want you to listen to Melissa's words very closely as she compares having years of leukemia to just a few weeks of ARDS and how she feels about the two things. Listen closely.
I've never dreamed after this had leukemia, done 2 years with it and chemo and all that, and I never dreamed that anything else could be worse. And this was so much worse. It was more spiritually, emotionally, physically, intellectually challenging than even cancer. If you presented me with ARDS and cancer, leukemia, I would choose leukemia.
And so again, that's pretty shocking to hear that our patients would rather have leukemia for years than spend even but a few days or weeks with us. And why do they say this? And what are they experiencing that makes her feel this way? And she is not alone, as you will learn. So listen to her and her husband talk about what the experience was as she tried to recover from her period in the ICU with ARDS.
And I had and the tubing was, I was still there. And I remember I was so weak, I could hardly lift my limbs on me. I could not sit up. Once they did get me in an upright position, it was absolutely terrifying. I couldn't walk. I couldn't stand. I had to learn how to swallow.
I remember the first time he said, it'll be several months in rehab. And I was like, well, this is pneumonia. And it really wasn't the illness that she was recovering from. It was the immobilization that she was now needing to recover from. And when she walked like 10 steps, that it was back to let's shoot off the gun, let's pop the champagne, let's have a party, because she took 10 steps completely on her own. And you think of that of being someone who's had a stroke, not someone who's just been laying in a bed.
And I think this is a brilliant description of the post-ICU survivor's experience that we actually almost never get to see. And what are the things that go into the long-term consequences of critical care? And I think this is summarized nicely. Clearly, two major areas that are impacted in our patients are first the brain. And I think our department has done a lot of work to try to improve this in post-operative cognitive delirium and postoperative cognitive dysfunction. But to give you some sense, this is a study from Wes's group that showed that in a 12-month follow-up, even youngish ICU patients, 34% of patients a year after they left us have cognitive deficits similar to moderate traumatic brain injury. And 25% of them have what appears to be mild Alzheimer's that can go on for years. And can be quite devastating. And in fact, clearly, as the study showed, these patients are at extremely high risk for cognitive dysfunction. And the longer they have delirium in the ICU, which is why it's so critical to treat it, the more likely they are to have dysfunction at many months or even years after their stay. 50 to 70% of patients on a ventilator for more than a few days will have this kind of cognitive dysfunction. And we'll talk about what it does for the rest of their lives in a moment. And then just as impactful, or perhaps even more so, is the ICU-acquired weakness. And of course, Margaret Herridge is the mother of this. She's a physician in Toronto who traveled all over Ontario, visiting her patients for up to 10 years in their homes, doing assessments of their physical function. She's really a legend in our field. And she asked them some basic questions. She asked them the SF-36, which is a quality of life score. Can you go up the stairs? Can you go to the bathroom? Can you go outside and walk? Can you do the things you want to do in your life? And at 3, 6, and 12 months, this is the scores that the patients reported. At 3 months, they reported a 0. At 6 months, their physical function score was a 0. And at 12 months, it was a 25. And perhaps you think that's an improvement. If I was to ask you these same questions right now, this is what you would score. you would score nearly a 90. This is the quality of life our patients have at a year. And these were largely 40 and 50-year-old ARDS patients, not 80-year-old patients like we take care of more and more. She then followed them up. The New England Journal asked her to follow up at 5 years, and most of these disabilities had not improved. People still walk their 6-minute walk test at 2/3 of predicted for their age, 5 and 10 years later. So these people leave, they're not getting the help they need, and they're not recovering. And in fact, half the people in their 40s and 50s who've had any time on the ventilator more than a few days, half of these people will not go back to the jobs they did at a year. I will tell you, Melissa never went back to the job she did as an accountant ever again because she was cognitively unable to do so. A third of these patients, like Melissa, will never return to the jobs they did. And these are young people who are losing their lives in our care. And no one's immune from this, no matter how young or how old. Jackie Renisha, I think, says it well. This is the defining challenge for us in critical care and perioperative medicine for the next century. And he says the emerging picture of ICU survivorship is disturbing. In the year or two, and actually more post-discharge, patients are ravaged. They can't walk. They can't think. Their lives are often destroyed, and they won't function like before. And many intensivists, and I get emails from people all over the world asking for help, especially with the physical dysfunction. They are desperate to get their lives back and have nowhere to turn. And so I think that's what we're trying to address in the future, both here at Duke and I hope around the world. 60 to 80% of ICU patients on a ventilator more than a few days will suffer these lifelong, often consequences. Major surgery patients have them too, as we'll discuss. So this is an epidemic for our patients. And why are we losing this quality of life war? Well, a major reason, and I'll show you that this ties not only to the body, but to the brain in a moment, is that an ICU or major surgery patient can lose 1 kilogram of lean body mass a day. And as I will show you, that is a devastating effect, not just for the short term for them, but for the rest of their lives and all of our lives if this happens to us. And that's because the body, of course, is not geared or built to survive these kinds of injuries and illness. So the hypermetabolism and catabolism of these patients persists for months to years. A burned child will remain catabolic for 2 years after they leave the burn unit. And in fact, Reed Vandenberg is studying in a grant that I reviewed and was just blown away by the survivors of both pediatric and adult ICU and their children and the epigenetic catabolic signal that's passed on. She's also studying 9/11 survivors and children's children of the Holocaust to see if the epigenetic changes that happens in our patients actually are passed on. And again, as you heard Melissa's husband say, it isn't even so much the illness, it's the bed rest. If I was to lay one of you in your 20s down in bed for a month, you wouldn't be able to walk. NASA did these studies in the astronauts. If I was to lay an elderly person over 65 down for just 10 days, healthy person, they lose 3 times as much muscle mass as the 28-year-old who laid down for a month. And if they're sick elderly folks, they lose this muscle mass in 3 days. And anyone who's around within the ICU hears me tell the patients every day, the bed is evil. I don't want you in the bed during the day at all. In the chair or walking, beds are for sleeping. If you're in the bed during the day, beds are for dying and the complications they bring. And this is what they bring. And although patients gain weight back, this weight is not muscle. This is fat because the catabolism of these patients persists. And this is our challenge to reverse. Because again, we're not evolved to this. Mother Nature doesn't want any of our patients in the OR or in the ICU to survive this. And so we don't have the metabolic machinery on our own to do this. And this is an epidemic. This is the epidemic we face in critical care and perioperative medicine. And we need to be better. And how can we do that? And we're going to talk about that today, and the opportunities I think uniquely we have here at Duke, and I think in the future in many places, to combine therapeutic nutrition with advanced physical therapy. And I think it's going to take the techniques that Olympic and professional athletes use to improve their performance to recover the basic performance of these patients. How many people on here on Zoom have run a marathon? Raise your hand. There's quite a few in the room. How many have ever run a race at all on the road? So many. So all of you know, you just don't wake up one morning and decide you're going to run a marathon. You have to train, you have to prepare, you have to eat right, you have to do all the things right. And for our patients having major surgery or recovering from the ICU, this is the marathon of their lives. Never will they train for anything more important than the major oncologic surgery, the major cardiac surgery, or the ICU unexpected visit that they're now having to recover from the trauma or other injury that brought them to us. And if we're going to do this, just like an elite athlete would do it, we have to personalize the way we do things. And that's true for their nutrition. That's true for their exercise. That's true for every aspect of their care, much like we would titrate their vasopressors with their blood pressure or their blood gases to titrate their ventilator. The same is true for nutrition and exercise. We have to measure because one size does not fit all. And that is true for all of our patients all of the time. And so we're going to need to be better, but how? And perhaps I often get this question, why would an anesthesiologist care so much about the things that happen after they're out of the OR, after they're out of the ICU? So why do I care so much, and why do I hope all of you do too? So how many of you have had surgery? Raise your hand. So pretty many people in the room for those on Zoom. Well, the reality is Atul Gawande has shown that every American will have 9.2 surgeries in their life. So I think, one, our jobs as anesthesiologists and surgeons are safe. But moreover, everyone's going to have this. Now, I would tell you a fair number of these are cosmetic surgeries, but they still count. How many of you have been in the ICU as a patient? Raise your hand. So nobody in the room is raising their hand, but in some rooms, a few people in the back. Well, Derek Angus has taught us, the editor for JAMA, works at Pittsburgh, that everyone in the US will average 1.7 ICU admissions in their lifetime. So someday, this will be you or someone you care about, or perhaps it already has been. Perhaps you'll escape some of these because, as many of you know, and it's happened in this hospital, I've used up some of yours. So this was me at age 15 with inflammatory bowel disease. And my passion for nutrition and exercise, honestly, comes from this experience. You can see TPN saved my life. That's why I'm close to my dietitians and advocate so aggressively for them. And during this time, I was hospitalized for a year, got 40 units of blood over about a 10-day period, and also my colon perforated, getting septic, ended up in the ICU after an emergent colon resection. Unfortunately, I tell you, you're cured of ulcerative colitis when you have your colon out, but that isn't totally the truth. Because what they don't tell you is that scarring your abdomen that never goes away keeps coming back to haunt you in the form of adhesions and obstructions and other complications. So through my life, I've had 27 abdominal surgeries, leaving me with 140 centimeters of bile. I'm short gut, and I have an ostomy, a JJ ostomy, actually I've had since I was a child. But given my passion for nutrition and exercise, which is as much by necessity as by interest, I can stay in pretty good shape. This was me in 2014 with my middle son visiting my grandfather, some of the best shape I was in my life. And then I ate some quinoa. If you've ever had surgery, don't let your patients or yourself ever eat quinoa. It's a guaranteed bowel obstruction, which happened about a month later. And I ended up flying all the way from Baltimore back to Colorado, where I was working, because we make terrible patients as physicians, to end up in my own emergency room in shock with a lactate of 10 with ischemic bowel, being operated on by a surgeon I had trained and graduated 3 months earlier. And I told her, go away, get someone older, which thankfully she did. They took me to the OR, and I spent 8 hours getting quinoa and adhesions removed from my bowel. Ended up in my own ICU and then also in my own hospital, writing my own parental nutrition. I was the director of the TPN service there as well. Gave myself 20 to 25 kcals per kilo. Thought that was enough. I was fit. I was healthy. 1.5 grams of protein. That was typical back then. And I went from looking like this to looking like this in 17 days. I lost 20 kilos. Remember I told you 1 kilogram of lean body mass a day? That is real, even in the healthiest of people. And it happened to me on TPN. And I'll show you, remember those numbers. I'll show you where I made my mistakes in a moment and how we can change things. Couldn't walk down the hospital hall without being short of breath in a week. I was running 5 to 10K a day before that. And I still had this happen. 6 months later, I couldn't pick up my smallest son. He wasn't that big because I was too weak. So I see recovery and prehabilitation for me as an everyday part of my life. And over 2 years, it took 4,000 calories, remember that number, and 2 grams per kilo per day of protein to recover. I like to show pictures of me with my ostomy because here at Duke, I see lots of ostomy patients who tell me they'd rather die than have an ostomy. And I encourage them by saying, you can do anything that you could do before with an ostomy. It's just no one tells you that. And then they say, well, how would you know? And I say, I have one, and they don't believe me. And I pull up my shirt and I show them, yes, I do. I can't believe it. So I always hope that gives them hope. And of course, exercise is critical too. Every bit as critical as the nutrition piece. So patient recovery is a personal passion of mine. I knew I'd be in the OR ICU again. And I always tell the surgery residents, that guy with the bad abdomen comes in at 2 in the morning, you don't want to see, please see him. That's probably me. Unfortunately, just a few years ago, it was. Thankfully, I was having recurrent bowel obstructions, and thankfully we have a wonderful bowel surgeon here in Deb Sudan, but this time it was adhesed to my ureter and it was causing renal failure. Every time I got obstructed, I got hydronephrosis and my creatinine skyrocketed. So it was going to take my life. And so because of these bowel obstructions, I volunteered to have Deb, which is one of the reasons I work here in some ways, because she's here, operate on me. Now, 10 years ago, it took me 2 years to recover and I lost 20 kilos. Now I'm 10 years older, having a much bigger surgery. And I've been taught for years that weight and strength and muscle mass loss is mandatory. Like I've talked to the patients in the post-ICU setting, you've heard me talk about what they go through. And so I began to think, gosh, how am I going to recover from this if I get sick again? Well, maybe it doesn't have to be that way. Maybe ICU-acquired weakness doesn't have to happen at all, which is something I could have never believed to be true before, but I believe it to be true now. So the key here is surgical and ICU recovery begins long before patients are admitted and continues long after they leave. So I realized I had to prepare a new way. And luckily, the data is beginning to show there are new ways to do this. And I have to thank Attilio for some of these slides that he gave me to modify. But the reality is the fitter you are when you come to surgery, the better you do. And this is just some of the data. And there's a lot of data for lots of different kinds of cancers and surgeries. It shows that fitter patients, as you could guess, do much better. People with higher peak VO2s, that's how we define fitness. We're going to talk about VO2 a lot. And muscle mass is just as important. So again, the people with more muscle mass have better mortality, better complication rates, go home sooner, and survive longer. And so you're going to hear muscle mass and VO2 peak over and over again. And this is true for our patients and for us. And so this is the idea that even frail, elderly people can be improved by things we can do before they have operations. And again, that frailty is reversible. I think Phil did a great job on these. And he really shows in these studies that the combination of cognition, nutrition, and physical activity interventions can markedly improve outcomes in patients. It's just almost no one does it, and no one has systems to do it. This is a really critical meta-analysis that was done looking at all the studies of prehabilitation just recently. Actually, this is one of my primary collaborators. She and I have worked together on lots of papers. She's a PhD RD from Canada. And what they looked at was a massive amount of studies, 186 RCTs, thousands of patients, hundreds of thousands of patients, actually. That's how far prehabilitation has come. And they looked at all the different kinds of prehab you can do, whether it's exercise, nutrition, cognition, or psychosocial. And then they did analysis where they looked at the different outcomes that matter to patients, whether it be complications, physical function, or the like. And it was a range of different kinds of surgeries. Many were cancer. And it was a very advanced analysis. They did a systematic network review to look at the components and overall effects, I think, which is critical of these interventions. And you can see for the different endpoints, there were large numbers of studies looking at this. This is not some new thing that we hope works. There is a lot of data for this. And the data was compelling. There were significant reductions of complications, and you're going to see consistently exercise and nutrition being the strong suits, as you might guess, in improving surgical outcome. Quality of life, again, improved by exercise and nutrition and exercise combinations. Length of stay, significantly reduced by exercise, nutrition, and exercise combinations. The story is almost always the same. And physical recovery being similar as well, that exercise and nutrition combinations are critical. And so I think the dream right is we will determine ways to do this kind of rehabilitation for all of our patients having major surgery, especially those at higher risk. And what are some of the things that I did involve as I tried to change my outcomes? Well, first, I needed to figure out how many calories I needed. So Yaron and others sitting in this room did metabolic carts on me. I needed to be able to follow my muscle mass. If you don't have optimal muscle mass, you have no business having surgery. And this is the future of how we'll define what is an eligible surgical candidate. And then, of course, VO2 peak testing. This is how you get your VO2. This is what we do in the pre-op clinic here at Duke and in the hospital rooms and in our rehab exercises. And then nutrition. I'll show this again, but these are all the things I take. When I travel to meetings, I have to take a separate suitcase. But these are all the things that I do to get ready every day, thinking the surgeon's knife is only minutes away. So I went to the OR, had a 13-hour surgery, lost 20 more centimeters of bowel, and also lost my gallbladder in the process. And this is me waking up in the SICU in bed 17, just upstairs from here. This is the night of surgery. And of course, I tell my patients they need to be out of bed, so do I. And so we need to teach this better. This is me walking at 12 hours, my lines and my tubes and everything else. And I did pretty well for the first few days, thinking, gosh, I'm going to escape this pretty unscathed. But unfortunately, at about 2 a.m. of the third night after surgery, I woke up with a fever, sweating, and my gown was soaked. And I looked down and there was stool pouring from my incision. and I was going into shock. And so Deb came and said, "You've got an anastomotic leak. I have to rush you back to the OR." And over the next 2 days, I had 3 surgeries, complicated by peritonitis, and ultimately leading me to be intubated on the vent in our own SICU. And again, this was the sickest I'd ever been in my life. Septic shock. I'm older. I've had a much bigger surgery. And she tells me the dread thing that I fear most is that I have a persistent GI fistula and she can't fix the leak. All of us who cared for fistula patients, if you have, you know what happens to them. They spend months to years sometimes in the hospital. Some of them never recover. And I began to wonder if I would ever see my children grow up, if I would ever speak to people like you in a room like this again. And how would I ever recover a meaningful quality of life to even live the life I'd led before? Because I thought, gosh, now I'm older, now I'm sicker. How am I ever going to recover? It took me years to recover 10 years ago. So I'm guaranteed, you would think, to lose significant muscle mass and ICU-acquired weakness and all the other things are almost insured now. Maybe not. Can we do this differently? Remember, I told you I had metabolic cart data to show that I could personalize my caloric needs. Remember, I told you I was feeding myself 2,500 calories. My resting is 3,000. So I was underfeeding myself. And then when I do rehab or physical therapy, you have to have an activity factor. So I needed 4,000 calories, but I didn't know it. And we don't know what our patients' needs are often. And I will tell you, just this week, we have started a metabolic cart service we have fought for 2 years here at Duke. So all of our patients can get these measures done, which is a huge advance. We've only been able to do it in research till now. So I would have TP in with 4,000 calories in, which I've never done before, probably will never do again, but that's what I needed. 2 years before, I had broken my arm skiing with my son, brushing off a barrel just like this, and discovered that I was testosterone deficient because I don't absorb cholesterol and the precursors well. So now I'm also on testosterone, which I think made an enormous difference in my outcome. I've watched it save the lives of burn patients for many years as a burn physician. This is critical, I think, to our patients' recovery. We'll talk about it. But I went home on TPN. My fistula didn't recover overnight, obviously. And so it took months of being at home on TPN to recover. But I think the key message is anyone can exercise. So this is me on my Peloton with my TPN line, my open fistula, my open abdomen, my IV line, and my ostomy, doing exercise at home.
The next time you feel like you can't work out, or you think of this guy.
So I don't want to get anybody's too tired tonight to work out ever again. And the reality is we tell our patients actually they can't do very much after surgery, but I think it's bad advice. We tell them they can't lift more than the tea kettle or 5 pounds for 8 weeks. There's lots of ways to move weight around to protect your abdomen that we should be teaching our patients, and every patient's different. So I think we hurt our patients' recovery. There's groups, patient advocate groups all over the world trying to change this. One size should not fit all. We need better physical therapy that gives patients a chance. The interesting thing was I noticed where before 10 years ago, the weight just melted off and I watched my face go to nothing. I didn't seem to see any difference in my face at all. And I lost a total of about 7 pounds the whole ICU stay. I gained all the weight back in the first few weeks on TPN. I would have told you this was impossible for the last 20 years. I've been teaching it. And then 8 weeks after the last surgery, I went to Deb and I said, my wife and I danced competitive Argentine tango. And we've been training for a competition for a year where I lift her over my head 5 times. Can I do it? And she said, does your wife weigh more than 5 pounds? And I said, a little bit, but don't tell her. She said, do you feel strong enough to do it? And I said, I do. And so just a few weeks after I got out of the hospital, we did this. So again, weight, strength, and muscle loss and ICU-acquired weakness and post-hospital weakness does not have to happen. And so if we're going to teach our patients to achieve this same outcome and achieve these same kind of goals, which are their goals, what does our focus in surgery and ICU clinics need to be as we think about starting our own here at Duke, which we're going to pilot, excitingly, BJ and Bosma have told me. I think we need to focus on 3 things, clearly. First, the bed rest and inactivity is a critical loss of muscle driver. Reduce anabolic hormone secretion. I'll talk about the incredible testosterone deficiency I see and treat here at Duke all the time as part of it. And then clearly, nutrition is critical, right? We have to address all 3 areas if we hope to our patients allow to recover. One or two of them alone will not do it. And I'll tell you why in a moment. So we need these clinics for these reasons, because no patient's going to know how to do this on their own. Most doctors don't know how to do this on their own. Why do we need them so bad? So I told you I get letters from all over the world from patients who are in the same straits that many of our post-ICU weakness patients go through. This was a letter that Mervyn Singer, who's a critical care physician in England, and a dear friend sent me, had one of his patients send me. He's a 49-year-old who was a competitive ski marathoner, if that's a thing. He does cross-country ski marathons. Very fit guy. Got community-acquired pneumonia. Was in the hospital just 10 days, ventilated for 1. Not very long. Lost about 5 kilos. Only hospitalized 10 days. Months later, he wrote me a letter and he said, months after this, I can't climb the London subway escalator that actually moves without being short of breath. I've worked with a trainer for the last few months and I can't improve at all. He said, being discharged from an ICU, even for an athlete like me, it's like jumping off a cliff. No one tells you what to do and no one tells you how to do it. This is not like anything I've experienced before, and I've been training my whole life. This is why we need them, and this is what they should look like. They should look like Medicine 3.0 clinics. Who knows what Medicine 3.0 is? Raise your hand. That's good. There's a few people in the room. This is the idea, and Peter Attia is the one who gets credit for this. He's a physician who has given his life to understanding the things that improve length of life and quality of life. And I would encourage all of you to read this book. It will change the way you look at your life in the world. And it's the idea that medicine should be preventive and proactive, treating and involving patients before they're sick, right? Medicine 2.0 is the idea we let you go your whole life eating poorly, smoking, getting diabetes, not exercising, and getting obese. And then when you get sick, we treat you with the meager medicines we have to extend your very poor quality of life at the very end of it. Medicine 3.0 is we start early and we address the things that actually help you live longer. And it's the same things, as it will turn out to be, that our ICU patients and our surgery patients need too. So what are the most important factors that will determine how long you live and how healthy that life will be? 3 things: muscle mass and strength, and I'll show you the data in a minute, cardiopulmonary fitness, and cognition. And the first 2 drive the third. These are more important than if you stop smoking, treat your diabetes, treat your hypertension, or do anything else medically that you could ever do by 10-fold. And I'll show you the data. So these are the same goals our ICU patients and our surgery patients need, right? This is the data for VO2 peak, and this is a large study, 120,000 subjects. Look what happens if you don't have good cardiopulmonary fitness, which is most of America. Your mortality over time is dramatically higher. Let's make this more compelling. This is comparing the low fitness patients here with the elite fitness patients here. And this is your risk of death over time going down from just your VO2 peak. This is just your cardiopulmonary fitness. I haven't gotten to muscle mass, right? Let me make it even more meaningful. So your risk of death, if you smoke, goes up 40% for your lifetime risk. If you have diabetes, it goes up 40%. If you have hypertension, it goes up 21%, and you decide not to treat these things. If you were the least fit person versus the elite person, you have a 400% chance of dying sooner. It increases your mortality 400%, 10 times out of any of these things that we spend a lot of time on. Even these less big jumps in fitness change your mortality, not 10 or 20%, but hundreds of percent. Even going from, let me go back, even going from the least fit person to just barely fit, as you will see, increases your survival by 100%. Even minor improvements in VO2 peak changes your life forever, and the quality of it is even more dramatic. This was confirmed in an even larger study of 750,000 people. Look at the dramatic effects on mortality by fitness versus the effects of the things we worry a lot about: smoking, kidney disease, hypertension. Those are trivial compared to not being fit or even remotely fit. So again, you and your patients will never be fit enough. There is always inklings to go. I can tell you John Lim is one of the fittest people I've discovered as I've talked to him. His VO2 peak's 54 and he's over 40. And I'll show you on a chart where that lies. He's elite fit. He's going to live a long time. Sort of a bus or a car hitting or something traumatic happening. But so again, compared to the things we worry a lot about, like hypertension and smoking, which only increase your risk of death 20 to 40%, being unfit cardiovascularly, 95 to 400%. And we have to think about what we're focusing on as patients or as doctors in talking to our patients. This never gets mentioned in the average primary care visit at all, nor is any physician trained to actually teach it. These are the charts. If you wonder what your VO2 peak should be as women at different ages and the mortality risk they pretend. So if you want to know, your own is happy to have you come visit us, and you will do a test in 5 minutes that will tell you what this number is for you right now. Our patients need to know this, and we need to improve it. This is for men. The first one was for women. John falls somewhere in here, by the way, if he's listening. So he's pretty good. He's 54 by estimate. So what about muscle strength? Muscle strength is critical as well, right? So if you have low muscle mass, you increase your mortality, and this is the people that, yes, do have low muscle mass, by about 50% just outright. Low muscle strength means much more. If you have low muscle strength, which is very different, right? 130% increased risk of mortality just by itself. So muscle mass is, as I will show you, perhaps more important even than fitness. And if you combine muscle mass with physical activity, clearly not being physically active is bad. It significantly increases your mortality. And these are regular free living people. But if you have low muscle mass and you're not active, that's the worst. And again, just having reasonable muscle mass can significantly modulate your lack of activity. As you can see, these risk rates, even if you have low muscle mass, if you're physically active at all, not even to the degree that the higher levels of physical activity, you can reverse that problem of not being active. And then, of course, the worst of all things is low muscle strength and not being active. That's what you don't want going into your life as you age. Again, hundreds of percent increase in mortality. So another slide that Tilly will share that I think is brilliant is a neat study that shows for every increased kilogram of strength you showed, you reduce your mortality 3%. And you reduce your risk of other mortalities as well. But it's compelling. It doesn't take much to change this. And if you compare which is more important, activity or strength, they looked at 1,500 men with hypertension. Even if the man's in the bottom half of being fit, they have a low VO2 peak. If they're in the top third of muscle strength, they still reduce the mortality by about 50%. So muscle strength can actually outperform activity, but they're both critical. And this is critical not only for survival, but also for function and the ability not to fall and the ability not to have cognitive disorders, as I will show you. Hand grip strength is directly tied to cognitive decline, such that if your hand grip strength as you age is a 40 kilogram hand grip strength, you have 40% lower risk of dementia than someone who has a hand grip strength of only 10 kilos, which actually is far more common, unfortunately, in our patients than we think. So this has a major effect on our brains. In fact, people with the ApoE4 gene, which is a huge risk of cognitive disorder if you're diagnosed with that gene, or even early in life, the primary intervention is muscle mass and activity in many ways, as well as sort of adapting the fat in your diet and a few other things. But this is how they treat people at high risk for cognitive dysfunction: exercise and muscle mass. So again, all diseases fall into this benefit category. I think that's critical. And then as we age to the elderly years, this becomes even more critical. The most common cause of accidental death as we age is falls. We take care of tons of them in our ICU. It's the top cause of accidental death in our elderly folks. And again, it's not the fall that kills them. It's their inability to ever return to a meaningful quality of life, their lack of balance and strength that led to the fall in the first place, and then the rapid decline of the little bit of strength and cardiovascular endurance they had to start that now plummets. And that's what leads to their death. So these are the things we should be focused on. And how are we going to do it? Well, this is our proposal here at Duke, at least. This is what I presented to BJ and to our department. This is what concierge clinics like the clinic that Peter Attia runs look like. Now, it costs $150,000 a year to see him, and he has a 3-year waiting list. Not everyone can do that. But in this setting, we hope everyone can, and this is how we're going to pay for it. These are the interventions for nutrition and muscle mass that we would advise doing. This is what concierge clinics do. And any of you know Matt McEvoy, who is the director of the peri-op service at Vanderbilt, when Vanderbilt wouldn't support the idea of him doing his clinic, he left and went into private practice a year ago. He's now running a private practice concierge clinic doing these things, trying to optimize people. I believe we can do this in an academic setting for all of our patients. And these tests that we do, whether it be metabolic cart, muscle ultrasound, CPAT testing, all are revenue generating. And I'll give you an example of that in a minute. And then our interventions, which will involve our dietitians and our physical therapists, will be correction of their nutrient deficiencies, Again, if you don't take in protein and your RDA of 0.8 grams per kilo leads to muscle mass loss in an elderly person in 3 weeks. So our patients are losing muscle every day because none of them are eating what they need to be. In combination with correcting testosterone deficiencies, what I will show you saves lives dramatically. In fact, and all of you will want to get yours checked, I hope, after this. That will be part of the care as well, because there's no one to do that outside of what we do. Again, when I start someone in the hospital, who's going to manage it afterwards? The surgeons aren't. And then exercise testing is critical too. These are all the basic tests that we do to evaluate someone's cardiopulmonary fitness, muscle mass, and all the things I told you saves lives and prolongs lives. Many of these things are revenue generating. And again, we already have physical therapy committed to wanting to do this. And this can all be done, as I will show you, remotely. We're doing it here, we're doing it at the VA. And then I can imagine expanding into testing for some of the other things like cognition that we do routinely in our trials, and looking at biomarkers like ApoE4 that predicts dementia robustly. Even if you're 20 years old, you have 2 ApoE4 genes, you're in trouble. There's lots of life changes you need to make now. Lp(a), huge acceleration of atherosclerosis. Drugs can cure this now in the last few months, and some of the other cancer risk biomarkers. And then I think the other key thing is we need to ask our patients what makes their lives meaningful, right? And what is it that defines quality of life? Because it's different for all of us. So Peter Attia does a beautiful job of this, and he says it's the Centurion Decathlon. Actually, the person in this picture, Ed Whitlock, is an 85-year-old who ran a sub-4 marathon, by the way. So even people over the age of 80 can be very fit and very active. And what is it they want to return to doing, right? And these are some of the things on his list that he asks his patients. And for a lot of them, they're common sense things. Can you get up off the floor with one arm? That's pretty important. If you fall, can you pick up your grandchildren? If your grandchild weighs 20 kilos or so, and you want to pick them up, you've got to be able to deadlift 20 or 30 pounds or sumo squat even a little bit more. If you want to do this when you're 85 or 90, you've got to be able to do twice that now when you're young. Carry 2 5-pound bags of groceries. Can you even go to the store if you don't maintain the ability to your bicep strength? Lift a 20-pound suitcase in the overhead. Can you travel? 20 pounds over your head is a 20-pound shoulder press. That's when you're 80. If you want to do it, you better be able to do 60 or 80 pounds now when you're younger. Balance on one leg for 30 seconds is what keeps you from falling when you slip on the ice or slip on the stairs. Have sex. This is important to people. It's a huge part of the quality of life surveys, especially in breast cancer and other meaningful surveys that have actually thought about what people really want. Climb 4 flights of stairs. Get up the stairs in your house. Open a jar. Takes a lot of hand grip strength. Again, you have to have more now if you're going to have it later, or do jump ropes. Just for fun, I thought about some of mine, and you would be interesting if you thought about some of yours. I want to be able to surf on the North Shore. That's my favorite thing in the world to do. Walk with a 30-pound dumbbell on each arm. Again, I'm going to have to walk with a lot more than 30 now to do that. Bench press 100 kilos. Do 5 pull-ups. Climb 90 stairs in 2 minutes. Needs a VO2 peak of 32. Dead hang for a minute. Dance with my wife and put her over my head. Not so hard now, but what about in 20 years? That's 130 pounds, 105 pounds, 110 pounds over my head. Carry my own luggage. Be able to travel. Walk up a steep hill. Be able to do push-ups. Be able to squat a weight. These are the kinds of things. Think about what you would want to do. And we have to ask our patients this because each one of those things requires a certain skill or exercise that would allow you to do it. And so how will we do it? Well, we'll do a lot of those things where we ask patients questions, but we'll also do the metabolic prep testing that saved my life, I think, in many ways, because you just not only need resting, remember this, if you don't move at all, but you've got to compensate for those calories. And right now we're guessing. Our equations are accurate less than 30% of the time. We have to know our patient's muscle mass. And I think this is an example of a revenue generating test. We've made proposal, and it's going through approvals now, to start this in the Prehab clinic. And this is one of the challenges we face. We have an incredible system. Our dietitian list is here today, in fact, from our Ponce clinic, where we actually screen all 60,000 patients for malnutrition at Duke. We only identify 17% of them despite that, having probably the best system in the United States. That number should be 30 to 50%. So again, we're missing lots of patients, and our malnutrition criteria now require that we measure muscle mass, or the coders and billers won't pay our malnutrition claims. So we're missing lots of people. This simple device, which takes less than 5 minutes, is the answer. It gives us lots of information, muscle mass, and there's cutoffs, as you can see, muscle quality, which is just as important, and muscle glycogen. We can actually see our patient's compliance with the nutrition. And it makes money. In the first month we do this, and just the 700 patients we'll see in the Ponce clinic or the Poet clinic, it's going to earn money in the first month. And it's going to earn a lot of money, even at just 700 patients we're planning to do. So these are revenue generating opportunities. It pays for itself and it improves patient care. We know that major interventions like this to improve perioperative optimization saved Allegheny Health System $7.8 million in complications and extended stay alone. And that was just last year. And the most common code rejected at Duke is a malnutrition claim because we don't have objective data for it. This gives us objective data. So again, this is an indisputable objective measure of malnutrition will allow us to improve care. So again, better financial outcomes for the hospital, better care for the patients. And again, it's simple to do like any other ultrasound we do. It looks just like this. So again, a bit of advice on nutrition that we share with our patients and I share with you. And it's pretty intuitive. Some of this is from Peter, some of this is from me. Don't eat too many calories or too few, but if you really want to know where that number is, you have to have it measured. We could do that. Consume enough protein and essential fats. 1 gram per pound is your target. Again, if you hit the USRDA, as you age, you will lose muscle in just a few weeks if you're not at 1 gram per pound. Get some fish oil every day. Most of us don't. There's no data for multivitamins really, but I take a stress bee because I think all of us lead pretty stressful lives. If your great-grandmother wouldn't recognize it, don't eat it. Don't eat it. Don't eat processed foods. If you bought it on the outside of the grocery store, it's better than if you bought it on the inside. So the outside foods are much better than the inside foods. Plants are good to eat. Animal protein is definitely safe to eat. We're all omnivores at base. The data for animal fats causing disease has been debunked for many years now. And cut out all simple sugars. This is the most important thing all of America could do. They call it the SAD, the Standard American Diet. This leads to most of the disease of the fastest growing metabolic and other nutrition-related diseases in the world. If we cut out the sugars in our drinks and the sodas and the simple sugars, go gluten-free, not because you're sensitive to gluten, because it'll cut out the simple sugars, you'll lose 10 pounds, I guarantee it. It's one of the most simple sets of advice I can give a patient. These, again, are the things I take every day. There's evidence for all of these. These are the kinds of evidence I share with people around the world to help them recover. They do make a difference for our patients when they're struggling. Protein deserves special mention. As we age, we become anabolic resistant. It takes more grams of protein to gain weight than it did when we were young. And so as we age, we all need more. And again, this guy does pretty well at age 70, but he does more than just eat right to look like this. But athletes know a lot. Again, 1.2 to 2 grams per kilo, 1 gram per pound, broken up through the day. Take it in before you go to bed. You'll gain more muscle mass. That's when you're anabolic. And you have to exercise as well. But lifting weights alone won't do it. There's a lot of data, especially in elderly people, that shows that strength training doesn't lead to any muscle mass increase if your protein intake is not at least 1.5 to 1.6 grams per kilo. So just lifting weights without protein. If you've ever had a kid or a friend or a young man who's like, I've been lifting weights for years and I can't gain any weight, it's their diet. Diet is 70% of all muscle mass gain. But critically ill surgical patients have it the worst, and they need other things besides just nutrition, besides just the basics. And then oral nutrition supplements are the only way to get this in. Nobody can just eat this much protein. And there's data for this. Giving high protein drinks to people for the 3 months after surgery or after hospitalization reduces mortality by half by itself and improves hand grip strength. Every 20 people we give these little drinks to, they cost us a few cents, saves lives. The last topic I'll kind of cover between this and exercise is the right nutrition enough to win the war? It's not. Nutrition alone won't stop the muscle mass loss in us as we age or in our patients as they recover. It will slow it, but it won't stop it. We're not evolved for this. We need help. And we can learn from athletes like this to do it because it takes more than just eating right to look like this. We need anabolic agents. And again, these shouldn't be given in the early phase. I worked at Bernius for many years. Everyone got an anabolic agent, but not for the first 5 to 7 days. If you castrate a rat, it does much better than if you don't in the first week after trauma. Not that we should castrate anyone, but our body does it for us, as you will see. I checked testosterone levels after that period, and many patients here at Duke, they're all severely deficient after 3 to 5 days. The published literature says most people, 95% of people will be deficient in 3 days. Most will be less than 100. I've seen 2 this week that were undetectable. The NIH has already shown that in burn patients, this saves lives, improves physical function, and is the only thing that will make a burn child or adult anabolic. You can feed them all you want, but they won't gain muscle mass without an anabolic agent or propranolol as an anti-anabolic. But people have always worried giving anabolic agents might increase the risk of death and poor outcomes. That's not true. The VA has done a ton of studies showing that just even free-living men with testosterone deficiency have much better survivals over years of time when their testosterone levels are higher or they're treated. You don't want to go through the end years of your life as a man, maybe even as a woman, with low testosterone levels. Your risk of death goes up extremely. And if you enter the hospital, low testosterone levels shown here, your mortality skyrockets. People that enter the hospital low testosterone have an infinitely higher mortality than those that don't. Significant increase in mortality in these patients. But the concern has been in past forms of the use of some of these drugs, increased cardiovascular risk. And this was oral forms of testosterone that are metabolized in the liver. The data says the opposite is true now. First, there was a New England Journal paper that showed no effect of testosterone on cardiovascular outcomes in many, many patients over time. And then a study in JAMA Internal Medicine showed in 43,000 testosterone deficient patients when an IM testosterone was used, which doesn't aromatize, that's the problem with the oral ones, reduced stroke and heart attack by 30%. What if you've already had a heart attack in the last year? People say, we won't treat them. That's not true either. Intermountain Health showed that patients with low testosterone who are treated with a heart attack in the last year, 80% less likelihood of having another major advanced cardiac event. So this is extremely protective, even if you've had a heart attack. And in the VA, they showed it reduces AFib, the bane of our existence in the ICU. Patients who have testosterone depleted, who are deficient, lower AFib rates. So again, this is critical. We have to teach our patients to do this, and we have to be the ones that monitor it for them. We only need a total in the ICU, especially because they're so low. This is how you replete it. There's a study in women going on in the NIH with hip fractures. They're using this dose in females to recover their hip fractures. There's a new oral form actually made here in the triangle. We're starting to work with them. This is absorbed through the lymphatics, does not have the adverse effects of old ones, and it doesn't kill off the cyclic release of testosterone. You get twice a day. You don't have to wean off of it. You can have children on it, and it actually maintains the cyclic release. It's a major advance, and I hope all of us are using it. You can get it at the VA already. So again, you need to check levels, and you have to titrate levels. You want 500 to 600 in a man, 400 to 500 in a woman, and you have to give enough protein or this is not going to work. So again, we've published papers on this if you want to learn more. And then finally, as we finish, we have to personalize exercise as well, right? You can't look at someone and tell if they're fit. Who has ever run behind this guy? I have many times, and you don't know why, because you can't look at someone and see fitness. So we need to learn from elite athletes how to exercise smarter. And it doesn't look like this. It looks like this. This is what your own and Megan in our lab does. This is exercise physiology testing or CPAT testing. It tells us an enormous amount of information from what substrate patients are using to how long they're going to live, in all honesty. This is complicated and expensive. If we want hospitals in Colombia and Brazil and Asia to do this, this won't be viable, but this will be. This is an inexpensive Bluetooth mask that we use routinely for all of our studies. It looks like this. This is me doing it. But we can do this in pre-op. We've done this in hospital rooms. It's done in 5 minutes, and it's validated and published. We had a large grant from the NIH to study this called REMHIT. We're studying in COVID survivors, and we're doing it with a multi-center trial with Wes Ely and others. This is the idea that we can get a CPAT test, VO2 peak, the heart rate at that VO2 peak, give them an iWatch and an iPhone, design a high-intensity program targeted to even 80-year-olds, as I will show you, send them home, and they will get coached by a physical therapist who lives in Florida and coaches people all over the U.S. One physical therapist, and that's all reimbursable, by the way. This is how we do it. We have a heart rate prescription we give them based on their VO2 peak. They do intervals like this that they can be watched live time and coached. And then that is combined with the strength, mobility, and exercise interventions that all are done without weights to significantly improve these as well. And this is part of our trial. And then, of course, we ramp people up as they improve. And so this is what we do when we do it. We did our original trials in bone marrow transplant population. We actually got 120% adherence. They exercised 4 days a week. They liked it so much. They improved their VO2 peak 25% in 1 month. That potentially reduces their risk of lifetime mortality by 50 to 100% if they can maintain it. These are some of the people in our trial now. This is a patient, 78-year-old. I've changed some of the names and details, but she had significant comorbidities. All the COVID patients do now. She just had a knee replacement. She came in with weakness and falls, never exercised a day in her life. She loved the study. Her husband said he'd never seen her fitter or happier than after she was done. She doubled her VO2 peak in 3 months at nearly 80, never having exercised a day in her life, doing this at home, and significantly improved her 6-minute walk test. So this works in the very elderly or the very young. This is a leukemia patient. Again, who came in, never exercised a day in his life, very sick, severe COVID. he doubled his VO2 peak, but now he put himself into a very highly fit range, even after just 3 months. People who've never exercised have massive gains, significantly improved his 30-second sit to stand and a 6-minute walk test as well. 3 months is all it takes. And then this is Attilio's data at the VA. If you don't know about this, you should. It is really exciting. This is his prehab data. He's doing prehab and rehab in surgical patients, which I think is brilliant. And this is a pilot study he did combining nutrition and exercise. And I think this is really excellent data. He does a lot of the same tests we do. He combines nutrition, protein, multivitamins, and vitamin D with a supervised exercise program. And it lasts for about 40 minutes. Combination, thank you. And so he's done a pilot looking for feasibility, and he's gotten a number of people all the way through. Some people are too fit, of course, but many people aren't. And what he found was both the protein, getting 75% of their supplements in a day was acceptable, and the prehab and rehab. Interesting, the rehab is not as good as the prehab. I think people are really motivated before surgery, but it led to significant improvements in step tests, sit to stand tests, and other measured anxiety and depression scores and quality of life. So again, this works. And we're doing it already. And now we just need to figure out how to make it a clinical program. So again, significant improvements in the veterans, significant gains from even less intensive a program than we're doing in our REM-HIT study. This is super effective. And now he's moving on to a multi-center trial of this. If you want to learn more, this is what it looks like. But I think the closing message is the reality is all of this is doable. And all of this is actually happening already here at Duke. The hardest part is when we enroll a patient in my REM-HIT study and they randomize to control, it takes a piece of my soul because I know they're not going to get the intervention that if they had gotten in the experimental group would change their lives forever, possibly, which is why this needs to become standard of care for our patients. And clearly we'll finish the studies and publish the data. But the reality is this works, and we have to address all 3 areas. If you want to learn more, we actually run a fellowship here at Duke where we teach a lot of this online. Your own teachers in this class, as do many experts around the world. We have 51 people in the fellowship this year. We had to turn down actually about a third of the applicants because we had too many people applying. And we have a clinical nutrition training program we do with CAPER, where we teach clinical nutrition research. We have funding for 2 fellows, and next year we're getting funding for 4, I was just told yesterday. So this program will grow. So we're going to train clinical nutrition researchers around the world. Many of these are from developing nations. But I think the final message is creating survivors is possible. And we have all the tools we need right now to avoid creating victims. And we can be better, but we need these clinics to do it. What should we focus on? The focus is simple. The things that change people's lives by hundreds of % in their survival and their outcomes: muscle mass and strength, cardiopulmonary fitness, and cognition. And we can measure and personalize and prescribe all of these just like we do drugs. This is the future. And again, this gives us a chance to take responsibility, not just for getting them out of the hospital, but for giving them back their lives. And if we can do this, we can take people who look like this. This was me not so long ago. Have them walking on their ventilators like this. And this is commonplace in South America and in Asia. And we need to make it commonplace here as well. And then hopefully have them leave the ICU like this. Or at least like this, which I was lucky enough to do myself. And in the end, this is what our patients want. And this is what they have the right and deserve to have. And with that, thank you for listening, and hopefully we can make this happen.